one cerebral hemisphere will coordinate the movements of another hemibody, because we have the decussation of the pyramidal tract, and this decussation it's related to the inferior aspect of the medulla oblongata pyramids. This is important to know. This is the main the main gross anatomy of the encephalon. Here is an axial cut of the midbrain of the mesencephalon. As I said, the anterior aspect is called the cerebral peduncle, and then the intermediate one is called the tegmentum, and then posteriorly we have the tectum. What I want to pay attention here is how one brainstem will subdivide it into two diencephalons and then two cerebral hemispheres. And this division is made by the presence of these two cerebral peduncles. So understand that we have just one brainstem. So we have just one medulla oblongata, one diencephalon, one medulla oblongata, one pons, and one mesencephalon. But then the mesencephalon, it has two cerebral peduncles. And because of these two cerebral peduncles, superior to the mesencephalon, we have paired structures. So we have two thalami, we have two cerebral hemispheres, just because of this relation. And then I always put this image here for you guys to see this image, how one brainstem will subdivide it into two. I like this notion of the central core, but the central core is really an enlargement of the concept of the diencephalon. Understand that superior to the mesencephalon, we have two diencephalon. Diencephalon is the thalamus itself and everything that's related to the thalamus. So epithalamus, metathalamus, and hypothalamus, this is all diencephalon. And the thalamus itself, that's called the dorsal thalamus or the proper thalamus. This is the thalamus itself. Everything that's related to the thalamus word is the diencephalon. And the central core is one enlargement of this concept. This is another view that I like to show that how inside each cerebral hemisphere we have one central core. One central core is just a block of structures. If we make a cut of these structures, we can see this formation of this block of alternating layers of gray matter and white matter. They are alternating themselves. This is an axial cut of the central core, and we can see alternating gray matter and white matter. If you come outside in, we have the insular cortex, extreme capsule, claustrum, external capsule, length-formed nucleus that is indeed made by two separate nuclei, the putamen laterally and the globus pallidus medially, but because of them together having this lens appearance, they have been named as the lenticular nucleus. Then medial to the lenticular nucleus, you have the internal capsule. Medial to the internal capsule, we'll have anteriorly the head of the caudine nucleus and posteriorly the thalamus. So just the thalamus here is really a diencephalic structure. All of these are basal ganglia intermingled with the capsules, the white matter capsules, and then laterally we have the insula that's already telencephalon. So some people will not like this view of the central core because we are putting together structures with different origins, with different functions, but morphologically it makes sense because everything here is together. So we also like this view to understand how the brain is formed, putting the central core in the middle, and then orbitating the central core, we have the lobes. We have the frontal lobe anteriorly, we have the parietal lobe superiorly, occipital lobe posteriorly, and the temporal lobe inferiorly. Then we have the fifth lobe of the telencephalon, that's the insular lobe at the lateral aspect, and making these two C's around the thalamus, we have the limbic lobe. The limbic lobe is called the limbic because it's going around. It's called limbic because it is around. It is at the limbus, it is around. And that's why it's making these C's. So we have an inner C made by the amygdala, the hippocampus, and the fornix. This is the inner C or the subcortical C of the limbic lobe. Inside we have the thalamus, of course. And then we have the outer C. We'll come to this later, but we have the cingulate gyrus and the parahippocampal gyrus. This is an outer C. Here is the brain itself, subdivided by the forks into these two cerebral hemispheres. And we have the hemispheres, and they are really detached from each other. The only structures that are connecting both cerebral hemispheres are the commissural fibers. The most important commissural fibers of the mammals, including us, of course, is the corpus callosum. But we have other commissures that are not really that important functionally for ourselves anymore. For example, anterior commissure, posterior commissure, limbic commissure. These commissures can be cut by the neurosurgeon without having any major neuropsychological interference for the patient. But of course, you cannot cut all the corpus callosum. So understand the cerebral hemispheres up to a point really separated between themselves, but just connected by the corpus callosum. This is the major commissural fiber pathway of the brain. And then each cerebral hemisphere, how we will divide each cerebral hemisphere. So Louis-Pierre Gratiolet came with this idea of subdividing the cerebral hemisphere into different lobes. So he put 5 different lobes. This is an anatomical idea, but in fact, the cerebral gyri, they continue between themselves. There is not a natural subdivision between the different cerebral lobes. So in the beginning, he took advantage of the natural separation between the bones of the skull, and he related the separation of the bones to the separation of the cerebral hemisphere, the cerebral lobes. Of course, we didn't know much about the brain anatomy at that time, but at that time we already knew about the bones. So we were using the sutures, the cranial sutures, to divide the brain itself. And then we began to understand more about the brain surface, and we stopped using the cranial sutures to divide the brain in its lobes, and we started to using brain anatomic landmarks to divide the brain in its different lobes. And nowadays we come to a system that most schools will use. So first of all, we're going to look for the lateral sulcus of the brain, also called the Sylvian fissure. The Sylvian fissure is dividing a space superiorly made by the frontal lobe and the parietal lobe from a space inferiorly made by the temporal lobe. And underneath the Sylvian fissure, we'll have inside the Sylvian fissure, really deep to the Sylvian fissure, we have the insula. Another major anatomic landmark is the central sulcus. The central sulcus is separated from it can be seen differently from the other cerebral lobes by 3 main anatomical aspects. First, it is oblique sulcus. It's almost vertical. We called it oblique because it's a little bit folding backwards. So it's called oblique. It's also one isolated sulcus, meaning that it usually does not receive important sulci anteriorly or posteriorly. It's really isolated inside this part of brain here. And it's also a continuous sulcus. This is another concept. The sulcus can be interrupted. For example, the inferior frontal sulcus and the inferior temporal sulcus, they are usually very interrupted, but not the central sulcus. So if we go by these 3 rules, so it's oblique, it's isolated, and it's continuous, it's easy to see where the central sulcus is. And because every one of us, every human being will have a central sulcus, it is used as a cerebral landmark to divide the frontal lobe anteriorly from the parietal lobe posteriorly. And now we're going to trace an imaginary line coming from this aspect, this bulging aspect of the inferior margin of the brain. Is called the preoccipital incisure or preoccipital notch. It's a nice name because it's preoccipital. It's just in front of the occipital lobe. So that's called preoccipital notch or preoccipital incisure. And we'll draw this line beginning at the higher aspect of this notch to the parietal occipital fissure, not really seen at the lateral aspect of the brain, but really easily seen on the medial aspect of the brain. We're going to show it later. So putting together the preoccipital notch to the parietal occipital fissure, we will draw this line. Posterior to this line, we have the occipital lobe, and then anterior to this line, we will connect the midpoint of this line to the inferior, to the posterior aspect of the sylvian fissure. We have the parietal lobe superiorly and the temporal lobe inferiorly. So here we have the 5 lobes of the lateral aspect of the brain. We have the frontal lobe, parietal lobe, occipital lobe, temporal lobe, and insular lobe. But the brain has 6 lobes. Where is the 6th lobe? The 6th lobe was described by Paul Broca about 150 years ago. He noticed that some structures are made in this round, this ring around the thalamus. And then he put this idea of a limbic convolution, meaning around the thalamus. And as you can see, the cingulate gyrus that is just lying over the corpus callosum, it's called the cingulate gyrus. It has it gets smaller posterior to the splenium. It's called the isthmus of the cingulate gyrus, and it continues itself with the parahippocampal gyrus. The parahippocampal gyrus harbors the hippocampus, and that's why it's called the parahippocampus. It is formed along the hippocampus, and that's why it has its name, parahippocampal gyrus. If you put the parahippocampus, isthmus, and cingulate gyrus, it forms the C. It's called the outer C, or the cortical C of the limbic system. Then inside the parahippocampal gyrus, we have the amygdala anteriorly and the hippocampus posteriorly, and the hippocampus continues posteriorly with the fornix. The fornix is really the outside output, is the efferent fibers of the hippocampus. So the information of the hippocampus continues with the fornix, and the fornix continues medially and inferiorly with the mammillary body. And this is also a C. This is called the inner C, or the subcortical C of the limbic lobe. This anatomy, surface anatomy, has been revised by many neurosurgeons, because the more recent, the more updated neurosurgery is done by is made a lot by the natural corridors of the brain. And to enlarge these corridors, we have to use microdissection techniques. So we use the microscope, we use very fine tools, fine instruments to get inside the sulci and the fissures of the brain. Of course, we will have to deal with the vessels. Arteries and veins are inside these natural spaces of the brain. But if we do this with precision, with microsurgical techniques, we can really unfold the brain. We can get inside the natural corridors and up to a point reach a lot of cisterns, spaces inside the brain, even the basal cisterns, for example. And a lot of lesions are not really inside the brain. For example, metastases, meningiomas, craniopharyngiomas, vascular lesions. They are just inside these natural spaces of the brain and can be reached without going through the brain, just the neurosurgeon navigating the natural spaces of the brain. Inside this big subject that's called the surface of the brain, we made a lot of studies regarding the cranial-sulcal relationship. We came up with these key points. That's really a set of key points that we can understand how the skull is related to the main sulci. This is a big paper that we published with Professor Ribas, my father, Guilherme Ribas, also a Brazilian neurosurgeon, and a group of other researchers as well. And you can look this at the Neurosurgery Journal, and we put together all these relationships. If you want to place your craniotomy related to a given sulcus, if you want to really if you don't have all this technology, for example, neuronavigation, we use these craniometric key points. This is really helping us. It's some landmarks that is gonna make it easier. So now at the second part of our talk, I want to show for you guys each blueprint of each cerebral surface. So we have 3 cerebral surfaces. We have a lateral surface, also called the supralateral surface because it's making this round turn superiorly, or convexity of the brain, 3 names for the same surface, so lateral, supralateral, or convexity of the brain. There we have a medial aspect of the brain, medial surface of the brain, and we have one inferior or basal surface of the brain. Let's see the blueprint, how each surface is organized. The main structure, the main anatomical landmark about of the lateral surface of the brain is, of course, the Sylvian fissure, dividing frontal and parietal lobe superiorly from the temporal lobe inferiorly. But don't understand the Sylvian fissure just as this lateral aspect. Understand the Sylvian fissure also with this ventral aspect, or what has been called the stem of the Sylvian fissure. This is the brain seen anteriorly, and we can see the temporal lobe inferiorly. This is the stem of the Sylvian fissure. This is a magnified view of the stem of the Sylvian fissure. Here is where the first segment of the MCA, the middle cerebral artery, is going through. So M1, it goes from the origin to the limb and insula. This is where M1 would be. And then the second division, M2 already over the insula, M3 over the opercula, and then M4 already at the lateral aspect of the brain. This is the major corridor of the neurosurgeon, splitting the Sylvian fissure to get deep inside the brain to reach the basal cisterns and to treat pathologies that can be at that site. This is a notebook, almost 100-year-old book, and it has this notion of lack of consistency. If we see all the brains, even our right side to the left side, it will be different between everybody. And these differences we have to consider in our plan, is in our blueprint of the brain. So, for example, here is the inferior frontal gyrus. The inferior frontal gyrus is subdivided into 3 parts. The most anterior one is called the orbitalis, the pars orbitalis. The intermediate one is called the pars triangularis, and the posterior one is called the pars opercularis because it's already over the insula. That's why it's called opercularis. And it's really the connection of the inferior frontal gyrus to the precentral gyrus. So see here the subject in the middle. Where would be the pars triangularis? Perhaps here. And the subject on the right side, pars triangularis, perhaps here, really far away from the Sylvian fissure. So you can see this lack of consistency. It's very common to see this lack of consistency. But all brains will follow up to a point blueprint. So I'm trying to make it short phrases for you to remember this blueprint. So first, see the lateral aspect of the brain and look for 3 poles. We have a frontal pole, a temporal pole, and one occipital pole. At each of these 3 cerebral poles, we'll have a merging of 3 cerebral gyri. So 3 frontal gyri will merge at the frontal pole, 3 occipital gyri will merge at the occipital pole, and 3 temporal gyri will merge at the temporal pole. So 3 poles, 3 gyri for each given pole, and the names of these gyri are really easy: superior, middle, and inferior one. Then we have an ellipse. An ellipse in the middle of the lateral aspect of the brain is formed anteriorly by the precentral gyrus and posteriorly by the postcentral gyrus. And as I said, the central sulcus is in the middle, and it's really an uninterrupted sulcus. And because because of this being uninterrupted continuous sulcus, it makes the gyri anteriorly and posteriorly will make this ellipse. So some people will also call this the central lobe of the brain. And then the parietal lobe posteriorly, divided by an anterior to posterior sulcus called the intraparietal sulcus. Intraparietal sulcus is a nice name because it's inside the parietal lobe. So intraparietal sulcus. Superior to the intraparietal sulcus, we have a quadrangular piece of brain. It's called the superior parietal lobule. And then inferior, we have 2 arched gyri that together will constitute the inferior parietal lobule. The anterior arched gyrus is called the supramarginal gyrus because it's over the posterior margin of the Sylvian fissure. This is why it's called the supramarginal, over the posterior margin of the Sylvian fissure. And then Posteriorly, we have another arched gyrus called the angular gyrus. The Sylvian fissure is also at the lateral aspect of the brain, but really inside the Sylvian fissure, and it has a forming. I will show this later with a short gyri and long gyri. The middle aspect of the brain is very consistent. If we take all of us will follow pretty much this system here. So the first structure that we want to look for is the corpus callosum. The corpus callosum is not really cortical surface, but it's really easy to see. It's a very white structure in the middle of the middle aspect of the brain. Overlying the corpus callosum, we have the cingulate gyrus. The cingulate gyrus continues posteriorly with this narrowing called the isthmus of the cingulate gyrus, and then continues with the parahippocampal gyrus already at the inferior aspect of the brain. This is the cortical C of the limbic structures. Then we see how the cingulate gyrus continues with the gyrus rectus, really at the at the inferior aspect of the frontal lobe. Here is the gyrus rectus, and the gyrus rectus continues itself with the frontal, the superior frontal gyrus, without a clear separation between them. They just continue one with another one. So this all here is superior frontal gyrus. Between superior frontal gyrus and cingulate gyrus, we'll have the cingulate sulcus. If we follow posterior the cingulate sulcus, it ascends posteriorly and marks the posterior margin of the paracentral lobule. This is why this sulcus here is called the ascending marginal ramus of the cingulate sulcus, because it's the posterior margin of the paracentral lobule. And so what is the paracentral lobule? The paracentral lobule is the most medial aspect of the pre and the post-central gyrus, but here seen at the middle aspect of the brain. It's called the paracentral lobule, paracentral lobule. Posterior to the paracentral lobule, we will have this quadrangular piece of brain that laterally is called the superior parietal lobule. But here, seen from the middle aspect, it has another name. It's called the precuneus. So the precuneus is the superior parietal lobule, but seen from this middle point of view. Posterior to the precuneus, we have a very deep and easy to see fissure of the brain. It's called the parieto-occipital fissure. It's a good name because it's divided anterior the parietal from the occipital posterior. So parieto-occipital fissure. Posterior to this fissure, we have the cuneus. Have this name because of this triangular appearance. It's called the cuneus. Okay, so the cuneus is this triangular appearance of this piece of bone of brain here. Inferior to the cuneus, we have the calcarean fissure. The calcarean fissure that harbors the primary vision cortical areas, not the sulcus itself, but what is superiorly and inferiorly to the calcarean fissure. Superior, we have the cuneus, as I said, and inferior, we have the lingual gyrus. I like this old name, lingual gyrus, because it resembles a tongue. It resembles something that's goes posterior, lingual gyrus. But some more, I would say, more recent work will call this gyrus as the temporal occipital medial gyrus. So medial occipital temporal gyrus. This is another name of the same gyrus, okay? But I like this old name, the lingual gyrus. If we see underneath the brain, we have the inferior aspect of the brain. We have first interhemispheric fissure. Lateral to the interhemispheric fissure, we have the gyrus rectus as well. So the gyrus rectus can be seen on the medial surface, but also in the basal surface. Lateral to the gyrus rectus, we have the olfactory groove or the olfactory fissure, harboring the olfactory tract. And then laterally to this fissure, we have the orbital gyri. The orbital gyri is seen them subdivided by this H-shaped sulcus that is dividing the orbital gyri into one anterior, posterior, and lateral and medial orbital gyri. So we are going to look here for this H-shaped sulcus. So here we can see the H-shaped, but in some frontal orbital surface, we will not see the H shape. For example, here is the Y shape. but it's just to stress this concept that we want to look for these 4 different orbital gyri. This is one anterior, another one posterior, a lateral, and a medial orbital gyri. Then at the temporal, occipital, basal region, we will look for these 3 arrangements coming from anteriorly to posteriorly. The most lateral arrangement is made by the inferior temporal gyrus continuing with the occipital, with the inferior occipital gyrus. They just continues itself one with the another one. There's not a clear subdivision between themselves. But if we take the preoccipital notch, we will see this division. So anterior to the preoccipital notch, we'll call inferior temporal gyrus. Posterior to the preoccipital notch, we'll call inferior occipital gyrus. But it's really indeed the same piece of brain continuing between themselves. More at the midline, close to the midline, I already talked about this. This is the parahippocampal gyrus, and the parahippocampal gyrus will harbor inside the hippocampus, and that's why it's called the parahippocampal gyrus. The most anterior aspect of parahippocampal gyrus folds itself into this hook-shaped appearance, okay? This hook-shaped appearance receives the name of the uncus. So the uncus is the most anterior part of the parahippocampal gyrus that is folding into itself. It's folding backwards and having this shape of a hook, okay? This is why it's called the uncus. Between the lateral and the medial arrangement, we'll look for a gyrus, an intermediate gyrus, that I also like the old name. It's called the fusiform gyrus because it falls in a fusiform, also an ellipse. So a fusiform between lateral and medial gyri. The most recent name is called the lateral occipital temporal gyrus. So both names are accepted. Medial and lateral occipital temporal gyri, or lingual and fusiform gyri, okay? And I just want to end my lecture showing the arrangement of the insula. The Turkish people is very proud of having Dr. Ture and Dr. Yashagil, and they came up with this very elegant paper, a little bit old paper, but still very, very recent. About 25 years ago, they came up with this paper, and they put the names of all these insular structures. So anteriorly, we have an anterior compartment made by short insular gyri that is converging into an apex, and posteriorly, we have long insular gyri that will not meet the apex. They will continue more to this part of the insula here called the Yemen insula. And between the anterior and posterior compartments, we have the central sulcus of the insula. I just wanted to show a picture of this and a picture with during my fellowship with Professor Rotten. Always nice to have mentors, to have people that inspired us. And this is when I finished my fellowship with Dr. Rotten about 12 years ago, with, of course, friends here and Dr. Rotten, as you guys know. Here is my email if anybody wants to get in touch with me. Here in Brazil, I work at these 2 institutions, at the left, the University of São Paulo, and at the right, the Albert Einstein Hospital, very known places here in Brazil. If everybody wants to visit us sometime, please send us an email. And thank you, Dr. Najiza and Dr. Abuzer, for having me here. It's an honor.
Thank you, boss, for this great lecture. And I'm lucky. I will give a lecture about surgical neuroanatomy next week. I will copy your lecture.
I'm honored to teach you something.
And
excellent.
We will continue with Amit Tampa. Then, if any question, we will take after both lectures, because I think they will talk the similar things. Professor Tapa, you can present your lecture, please.
Thank you, Officer. Well, let me share my slide. And it was wonderful listening to Eduardo. And while listening to him, I was just reminded of Professor Alberto Rotten. And he used to tell the same type of story, linking everything to what all he would say. Thank you once again for this opportunity, and I will be talking about a very basic but very crucial topic, craniometric points in the surface anatomy. I have nothing commercial to disclose in this presentation, and whatever remark I would make to some of the commercial products would be just for education and sharing experiences. Well, we all know that the navigation had actually started with the use of the ocean explorer using the polar star as well as the sun as the coordinates using the 16 devices. And now we have GPS system in our mobile phone, which uses the triangulation method to localize any part of the Earth. In the brain, we have the similar technology using the navigation system where we can even track the fiber tracks these days on the real-time image, on the images of the images of the patient on the patient's head as we are operating on the patient. Well, this may be of very much help, but then one of my medical students, while we were using navigation system, did ask me, then when we have all these advances, why we're still using craniometric points? Well, the answer to it is that we need to make a plan, we need to position the patient, and then we have to fix the patient and attach it to the navigation system. So before we come up to navigation system, we need to have everything decided on the base of the craniometric points. So craniometry is basically a scientific study to study the sizes, shape, and the proportion of the human skull. And craniometric points are those crucial landmarks over the cranium, which can be used to identify or measure these craniometric measurements. Now, the criteria of using these craniometric points have to be easily localizable, and they have to be consistent so that everyone who is looking onto the patient's skull can identify these craniometric points very easily. And the uses are definitely for surgical planning, neuronavigation, and real-time guidance as we are operating on the patient's head. And of course, in some cases, when we are using along with the radiology, we can even use it for a diagnosis, which we'll just touch upon in the end of the slides. So we have already discussed about the craniometry, but it started with the methods of physical anthropology and phrenology in the late 19th and the early 20th century, where the earlier scientists actually merged with the mathematical concepts to make certain primary mechanical tools to navigate to the lesion of interest. So slowly it started with the cerebral topography as was devised by Broca's theory of cortical localization, and it later moves towards the modern day of stereotic techniques. So it has seen the transitions over the period from. So as you all know, it all started with the exploration of the cerebral abscesses, and the early literature are full of way how they would clinically localize the patient's lesion based on the symptomatology, and then they will put it on the patient's head, the exploratory burr holes to find out these abscesses. Well, it will be always very important to quote the name of Pierre Paul Broca, who was supposed to be the pioneer of this studies, a French anatomist and surgeon. And when he reported in 1861 the first study of craniocerebral topography correlation, there was a study where he had very strategically placed wooden pins through the cranial perforation and then examined their position to the autopsies, that he could actually make an observation which is still true to date. He said that the upper end of the Rolandic sulcus, which we now call as SRP or superior Rolandic point, is between 40 to 50 millimeters behind the bregma, which is so true to the date, as well as a lot of things which he has then said has actually been true. And then he even used this technique to evacuate abscess in 1876. Sadly, 4 years later, he expired. And this is the figure of the brain, which he used to identify the speech area using the Broca-Champiers method. Well, beside this, there have been many scientists, many workers who have, throughout the last century, worked over these craniocerebral relationship. I'm just putting their names and the pictures so that they can be remembered for their contribution. However, one should understand that this particular craniocerebral relationship actually marks the localization of the cerebral gyres and sulci as according to the craniometric points. And as Dr. Rivas has already told in his presentation, that there can be anatomical function variations even between the two hemispheres. And that's why this found the complete function reliability solely on the craniometric points can be subjected to errors. And that's why one has to be cognizant of this fact. And even the underlying pathology can displace the gyres and sulci, can even involve it, particularly the intraventricular pathology, which can even dilate the structures. And the recent publications by many authors have actually shown that to the long-standing lesions, the brain starts having because of its plasticity effect, tries to replace the function of that particular involved area, and henceforth all these particular localization done solely on the basis of craniometric point should be supplemented by intraoperative function and neurophysiological testing. So this is the small pitfall I just wanted to notify before we embark on this journey of craniometric points. So when we study a skull, we always study the skull in 3 planes because it's a 3D structure. So we read on a mid-sagittal plane, we need to understand, but the axial plane is something which we all miss. And that's right, for the standard of for the purpose of standardization, we always take Frankfurt plane, which starts from the inferior orbital margin and goes to the upper margin of the external auditory meatus. So this plane, or the Frankfurt plane, is considered to be the mean horizontal plane of the axial plane, and all the perpendicular lines which are drawn vertically are taken perpendicular from this plane. So when we talk of the coronal plane and look at the anterior aspect, the most important craniometric point which we always come across is the nasion, which is the depression which is made by the fusion of the nasal bone and the frontalis bone. And then as you go up is the glabella, and then in the center is the sagittal suture, and the sagittal suture with the junction with the coronal suture forms the bregma. And then we have a frontozygomatic suture point, which is also very important because this is something which is palpable just above the lateral canthus and also actually marks a very crucial craniometric point from the front. When we look at the back in the coronal plane, then it becomes the fusion of the superior sagittal suture with the lamboid suture, which is the lambda. And when we come 2 to 4 centimeter below, it is the opistocronium. And 2 to 4 centimeter below will be the inion, and then there will be a superligament ligament and the asteron at the back. Now, when we look at the sagittal plane from one lateral aspect, the important craniometric point is again frontozygomatic point, and then is the superior temporal line, which is basically the attachment of the superior temporalis muscle, and then below it will be the squamosal suture, which is again another important point, and the pterion. And then when we look at from the up, then we have the the parietal bossing on either the side, which is also known as irion. And then we have the coronal suture, and then the lamboid suture, and in the midline is the sagittal suture. So these are the important craniometric points which everyone should know before we embark on this journey. Beside this, there may be other points like glabella, which we've already talked about. Then there can be opistheon. So unlike opistocranion, which is the most posterior protuberance, opistheon is the posterior margin of the foramen magnum, whereas the anterior point of the foramen magnum is known as basion. And then we have gnathion, which is the mentis, and then the gonion, which is the tip of the angle between the ramus and the body of the mandible. So pterion is something which we all should be cognizant, because this is the posterior part of the fusion of the coronal suture with the H-shaped structure, which is basically a fusion of the frontalis, temporalis, squamous, and the sphenoid bones. And the porion is basically the upper part or the superior upper part of the external auditory meatus, so which is also taken to be one of the craniometric point. So we have already covered about the irion, and the zygon is basically over the zygomatic process, the latermost part, and the gonion. So when we are looking up, these are the important structures which we need to identify. Now, this particular skull, which is basically showing the gyrus and sulci beneath and the bone above, actually shows the relationship of the nasion to the bregma, which is almost 12 to 14 centimeter. And the bregma, again, from the lambda is around 12 to 14 centimeter. And the lambda from the opistocronium is 2 to 4 centimeter. And the opistocronium to the inion is 3 to 4 centimeter. Now, this particular figure also shows the relationship of the squamosal suture line to the sylvan fissure. So you can see the sylvan fissure actually starts anteriorly with the squamosal suture, but then it moves up. And that's why the posterior sylvan point, which is the posterior most step of the sylvan fissure, basically lies above the squamosal suture, and it is much more closer to the superior temporal line as we see it. And then there's a portion known as the stephanion, which is basically the intersection between the bregma and the superior temporal line, which actually tells us about an important key point, which I will be discussing in the future slide. And then there is a preauricular depression, which is basically the depression which is felt just in front of the tragus, which is a palpable depression, which is also one of the key craniometric point. Then in the open face, you can see oral, staphion, endomorph, and vision. Well, this is not something which we will be considering more in the skull-based approaches. Now, when we talk about the size of the skull, the length of the skull is identified by the gap between the glabella and the opistocranion, whereas the width is between the urion and the urion on the other side, and the height is from the bregma to the basion. Similarly, over the face, it is the nasion to the nathion, and the width is taken from the zygon to the other side of the zygon. Now, when we talk of craniometric points, it is important to make three different parameters. One is a circular line, which starts from the nasion and ends into the inion and divided into 4 parts. So the third quarter of the part, which actually gives you an idea of a sylvan fissure when we started from the frontozygomatic suture and then extended to the third quarter of the telehotter line. So the first 2/3 of that line can actually tell you about the sylvan fissure. Now, the other 2 lines which are important for us to understand is the posterior ear line, which comes from the mastoid tip and goes perpendicular to the Frankfurt plane and hits 2 centimeters behind the midpoint of the telehotter lines. Well, that actually makes the point of the superior Rolandic point, or SRP, or actually tells you that the central sulcus actually finishes in the mid-sagittal plane at that particular point. And where it hits the sylvan fissure, it is actually a localization for central sulcus. Now, that point where it hits the sylvan fissure can also be made by the condylar line, which starts from the condyle and it goes up. And this line is almost 2.5 centimeters from the pterion. Now, beside this, there is a point known as Chatter's point. Well, this is identified by a 6 centimeter height from the osteomedial orbitomedial line. Now, this line is basically above the posterior sylvan point, and it is basically the area of the angular gyrus where we are nowadays in the area where we are doing an ECIC bypasses. So, mini craniotomy of 4 centimeter, which is centered over the Chatter point, can actually expose the M2 and M3 segments where you can do an ECIC bypasses. So when we do a craniometric point analysis, it is always very interesting to note how these sutures and these intersections are lying over the brain. And this particular figure actually shows that the central sulcus at the interhemispheric fissure, that is also known as superior Rolandic point, is almost 5 centimeters behind the bregma. But at the level of the superior temporal line, it is almost 2.5 centimeters behind. So this can also let us know that this is the central sulcus is actually moving behind, and that's why it is much more posterior to the bregma as when compared to the lateral aspect. And similarly, when we see the relationship of the taller heightened line, it can also be associated with this particular model. Now, Rivas has in his talk to talk about his key work on the sulcus and gyral key point, and I want to highlight this aspect here because this is very important for surgical planning. So one of these key sulcal and the gyral key points which has been made has been divided over the different cerebral surfaces. So the frontal opercular key point, which is basically the workhorse of all these neurosurgery which we done from the terminal craniotomy, is based on these key points. So one of the key points is the anterior cerebral point, which is basically the area where the stem of the sylvan fissure comes out on the lateral aspect, and it is pointed by the triangular lies just behind the pterion and directly hitting on the anterior sylvan point, and from where we can start dissecting the sylvan fissure either proximally or distally. And when we go behind it, we will reach a point known as inferior Rolandic point, which is nothing but a point where the central sulcus comes down into the sylvan fissure, and in some places can even hit into the sylvan fissure where the subcentral sulcus is hidden inside the sylvan fissure. So this inferior Rolandic point is actually lying at the 2 to 4 centimeter above the preauricular depression point. And this is very important point for us to understand, because this is the area where the facial gyrus will be lying. And so any corticotomy over the superior temporal gyrus or the middle each problem in the patient. And then the other point which is important to understand is the inferior frontal and the precentral sulci meeting point. So inferior frontal sulci actually intersects with the precentral sulcus at a point which is just between the 2 centimeter area below the Stephanion craniometric point, and it actually marks the anterior border of the precentral gyrus, and also the posterior and the superior border of the orbital gyruses. So this can actually be a very important landmark when we are trying to open this area through the neuroanatomy and all those. Now, the confusion with the gyrus anatomy is that these sulcuses, which are forming the upper lip of the ciliary fissure, can be too varied, as Dr. Ribas did show on his talk. So we actually made a mnemonic of 1V. So this meaning the proximal V or the anterior V is nothing but the triangularis gyrus, and then the middle C is basically the precentral gyrus going through the subcentral side gyrus into these postcentral gyruses. And this middle view is very much evident even when we are looking at the 3D rendered MRI scans. So one can even have an idea about that. And at the tip of it, where the central sulcus will be hitting into the sylvian fissure, will be the inferior Rolandic point. So this is a very important structure when we are trying to do, say, for example, a temporal lobectomy in a patient with epilepsy disorder. So we should try to limit our lobectomy till that point, because in the dominant hemisphere, one can have a speech defect if you go a little bit more posterior to that. And then the convoluted C, which is behind the last C or the posterior C, is basically the superior marginal gyruses, and which actually covers the posterior sylvan point. So some of the studies do show that the anterior sylvan point and the posterior sylvan point, the midpoint is the IRP. So one can actually have an idea about this. So using the craniometric points over the skull, one can easily identify these gyral and the sulcal element onto the brain. The other portion is the superior portion of the cerebral hemisphere, where we can actually see the superior frontal and the central key point. So one of them is the intersection of the superior frontal and the precentral sulcus. So this is the superior frontal sulcus and then the precentral sulcus meeting point. And this is usually located 3 centimeter from the midline and 1.5 centimeter behind the coronal suture. And this point is important because it is lying over the body of the lateral ventricle, thalamus, and a little behind the foramen Monro. So coronal sulcus actually lies over the foramen of Monro in the coronal plane, but the superior frontal and precentral sulcus meeting point lies a little bit behind it. So this is one of the landmark one can use to attack the ventricular pathology from this part. Then the other important point is the superior Rolandic point, as we have already talked about in the previous slide. So this is in the interhemispheric plane where the central sulcus intersects with the interhemispheric fissure. And this superior Rolandic point actually lies 5 centimeter behind the bregma. And this is one of the important landmark when we are trying to go through the interhemispheric approaches, because when we do a corpus callosotomy at this level, the chances are that one can easily go into the subsplenial cisterns into the pineal gland. So one has to be cognizant of the fact that whenever you're doing an interhemispheric fissure, try to keep this as a landmark and try to remain in front of it when we are going through the corpus callosum, or else with is very, very high chances that we will go into the posterior. And also the hemispheric approaches, which is placed before or like anterior to this SR troubles as compared to when you go behind it, because there are a lot of venous connections behind it. Apart from that, the other key points are the parietal key points. So the number one parietal key point is the intraparietal and the post-central sulcus meeting point. So this is the intraparietal sulcus, and then this is the intraparietal and post-central sulcus meeting point. This is actually placed 6 centimeter from the bregma and 5 centimeter from the midline. And the importance is that if you go 30-degree angulation into this particular point, one can hit into the trigon or the lateral ventricle. Then the other point is the irion. So irion, as you remember, is the parietal bossing on the either side, and this is a little superior to the superior temporal line and posterior to it. And the cranial and the cerebral localization is basically it represents the superior marginal gyrus, which is separated by an angular gyrus between an intermediary sulcus, and then it is behind the or posterior to the superior temporal sulcus and the cilium fissure. So one can have an idea about the supramandibular gyrus by localizing this irion point. Then is the parieto-occipital insulae, which is basically dividing the parietal lobe from the occipital lobe. And this particular cranial localization can be made by the intersection of the sagittal suture with the lamboid suture. So this actually lies at the angle on the either side. So this parieto-occipital insula can be identified by this landmark. Now, this is in a nutshell of these four parietal key points. So superior Rolandic point, which is 5 centimeter from the bregma, and then the parieto-occipital insula, which is at the intersection of the sagittal suture and the lamboid sutures, and then the interparietal sulcus and the posterior central sulcus intersection point, which is 6 centimeter from the bregma and 5 centimeter from the midline, and the superior marginal gyrus or the euphoron, which is the parietal bossing or the widest area on the lateral aspect of the skull. Now we will talk about the posterior temporal key points. So in the posterior temporal key points, the most important landmark is the posterior extremity of the superior temporal sulcus, now which is identified on the cranium as lying 3 centimeter above the intersection of the squamous and the parieto-mastoid sutures. So when we go above 3 centimeter, there will be a posterior extremity of the superior temporal sulcus. Now, this is important because when we go perpendicular into the brain, we can actually go into the posterior part of the hippocampus. And then we have the occipital key points. Now, the occipital key points is basically the opistocranion, and opistocranion is the posterior or the occipital protuberance of the occiput, and which actually lies over the apex of the calcarine sulcus. And if you see the axial plane, which is made by this particular point, it will be involving the posterior part of the calcarine sulcus, the anterior part of the lingula, and then the isthmus of the cingulum, and then one can actually go into the splenium. So this particular axial plane can be defined by this opistocranium cranial landmark. So this is an important landmark from the occipital approaches point of view. Now, there are certain basal supratentorial key points, which is very important when we are trying to hit the anterior, middle, or the posterior skull bases. So it starts with the frontozygomatic process key point, which we also known as McCarthy's key burr hole, as we all do it. But then there have been variation which has been there in the literature. Most people go 1 centimeter behind the pterion, but then if we go only like 1 finger breadth behind the frontozygomatic suture, or rather 5 to 7 millimeter behind and superior, we will be in a point where we can not only go towards the orbit, but can also go towards the frontal skull base, if in case we just change the direction of this particular key burr hole site. Then the other burr hole site or the key point site is the anterior temporal key point, which is basically just behind the sphenoid squamous suture line. If you go anterior, then we'll be going into the sphenoid bone. So it's always better to go behind, and this will be leading us to an area where the middle meningeal artery will be found. So this will actually let us open into the middle skull base. Then there's the preauricular depression key point, which is the depression which is palpable just in front of trachea. And this the anterior portion of the petrous bone. So this particular burr hole can actually lead you, a burr hole just above it can actually lead you to the anterior portion of the petrous apex, petrous bone. And then the other key point is the parieto-mastoid and the squamosal suture meeting point. So this particular burr hole, if in case made at this point, can actually lead you to the lateral aspect of the posterior part of the petrous bone. And then is the asterion, which is basically just behind the parieto-occipito and the intersection of the occipito-mastoid sutures. And here we can actually find the transverse sinuses as it just lifts over the transsagittal sinus. Over the sigmoid sinus, and then we can actually have the preoccipital notch, the plication of the dura arising at this when we are talking of the intradural association of the asterion. Now, and this is in the nutshell of all these 5 strategic burr hole positions when we are talking of the craniometric points when in relation to the skull-based approaches. Now, studies have shown that if in case we follow these landmarks, we can be very much be able to identify the cortical tumor, and to less extent in places of the subcortical tumor. So in this study, they have actually studied the accuracy of the navigation when we use the craniometric point. And then they found that if they used it for the cortical lesions, then the fair chances of getting the tumor or the pathology in percent. Grade 3 are those patients where the lesion had been outside the craniotomy site. So you can see the failure rate or the chances of not getting the lesion inside the craniometry of your craniotomy is far lesser when we are using these types of localization techniques based on the craniometric points. Now, techniques have changed over the years. Initially, people were using X-rays to identify that. Now people are using stereotypic devices. Days of numeric encephalography and angiography have actually been gone, but then people are still using it. Some centers are actually using these types of craniometric associations based on angiographic images. And then nowadays, navigation systems are all using CT and MRI systems. So a few words about the ventricular access point, because this also uses the craniometric points to hit into the ventricle. So the most common point which we all use for external ventricular drainage is the Cocker's point, so which is nothing but a point which is 3 centimeter lateral to the midline, and it is 1 centimeter anterior to the coronal suture, or 11 centimeter from the nasion. And the trajectory is towards the mid-pupillary line, and it is pointing towards the external auditory meatus on both the sides. So when we are trying to hit by using this trajectory, the frontal horn will be hit at the 6 centimeter depth. So this is something which we all can identify the phenomenon of Monroe while we're doing an EVD tap using a Cocker's point. Now, during the intraoperative exploration, when the brain is very tense because of the dilated ventricle, some of these landmarks like pains or Humes and Park points can be very helpful to go inside the frontal horn of the ventricle and drain the CSF to relax the brain. So Payne's point is localized by a 2.5 centimeter height from the floor of the anterior fossa and 2.5 centimeter behind. And this is the shortest trajectory, which is marked at 90 degrees to the cortical surface, hitting the ventricle at the depth of around 4 to 5 centimeter. However, when we go anterior, that is 2 centimeter anterior, that's a Park's point, then we will be hitting the ventricle at 5 to 6 centimeter depth. And when we go a little bit superior, that is the Humes point, 2 centimeter above, then it will be trying to hit the frontal horn in a little bit angulation, inferior angulation, and it will be hitting at 5 to 6.5 centimeter. Now, these targeting can also be done using an ultrasound guidance, because the skull is open, and under the vision of the ultrasound, one can even hit the frontal horn very easily using these targets. Now, the other point is the Kaufman point, which is basically from the frontal approaches, which is a very short trajectory, only 7 centimeter depth to the frontal horn. So this is defined by a point 5 centimeter above the nasion and 3 centimeter from the lateral. And what we are targeting is 3 centimeter point above the inium located at the back of the head. So one can easily target the frontal horn by using this technique. And then there's the Minovsky point, which is basically a supraorbital approach to the frontal horn again. So this is targeted with an angulation of around 45 degree from the midline and 20 degrees superiorly pointed. And at the distance of 5 to 6.5 centimeter, one can hit the frontal horn again using this particular technique. And in the tubes point, which is just for the mention, because I don't think so these approaches being done these days, but this was in the past one of the favorite technique, because you don't have to use a drill. Just by using a ventricular needle, you can easily tap through the supraorbital roof. So the idea was to go 45 degree above the orbitometer line, targeting towards the midline. At the 8 centimeter, you would be hitting the frontal horn. The problem was that the orbital and the eye injuries were very common. And then since you are going through the ethmoid sinuses, some problems of the CSF rhinorrhea can come up later. Now, Dandy's point is one of the common points which is being used for shunt placements. And now this is 3 centimeter above and 2 centimeter lateral to the midline, and the target point is the center of the 2 centimeter above the glavula. And the Frazier point is another point which we are using, particularly in the kids. It is 6 centimeter above the ilion and 3 to 4 centimeter from the sagittal plane. And then we are trying to hit the contralateral medial canthus in this target, and one can hit the ventricle and as short as 5 centimeter, the occipital horn of the lateral ventricle. So the Keynes point is used whenever we are trying to use an RMSOC or retromastoid technique or some suboccipital craniotomy technique for removing the tumor, and the patient's ventricle has to be drained and the same sitting in the same position. Then it becomes a very easy point for us to attack through. So the localization is 2.5 to 3 centimeter above the superior most part of the pinna, and then behind it. And then one can go perpendicular again to the skull, and the distance of 4 to 5 centimeter, one can easily hit the trigon of the ventricle. And then at the Sanchez point. So Sanchez point is basically targeting the temporal horn of the lateral ventricle. So this starts somewhere around 5 to 6 centimeter above the ilion and 2.5 centimeter lateral. And this is a little bit angulated 5 centimeter towards the lateral aspect, and it is angulated 30 degree to the orbitomeatal plane. So in this particular angulation, one can hit the temporal horn at 9 to 10 centimeter depth. So we all have heard about the asterion. So asterion is a landmark when we are planning certain posterior fossa approaches. Even authors are talking about using auricle as one of the landmarks, where the posterior most step of the auricle can give you an idea about the confluence of the sagittal sigmoid sinus to the transverse sinus. So this posterior confluence has not been marked through the bony anatomy. So this is one thing which one can use it for the surgical purposes. Beside this, craniometry is also being used for diagnostic purposes, particularly in the CVJs. So we all are aware of these atlases, particularly based on radiographs as well as on the CT scan and the MRI. So whenever to diagnose the basal invagination as well as diagnose the atlantoaxial dislocations, we actually use these craniometric points for the diagnostic reason. But I would like to keep this particular talk short in this part, because there were a lot of things which we've already discussed. So to conclude, craniometric points actually provides a validated navigation using the skull structures to the underlying cortices, venous sinuses, and the ventricular spaces. And these are very easily overlaid over the skull X-rays, angiography images, CT, and MRIs. So nowadays we can even read the MRI and CT scans and can use these craniometric points over the gyrus and sulci underneath. And this can also help to plan approaches and positioning the patient before we put the patient for the advanced navigation system. So with this, I would like to end the talk, and I will be available on this email for any further clarification. I will happy to take any questions. And I would like to invite all of you this November 14 to 16 to eastern part of Nepal for a national congress. Thank you once again for your patience listening.
I want to comment, Dr. Amit. First of all, very, very nice talk, very, very summarized all the key points. And I'm from Brazil. I don't know Nepal actually, but I would imagine that some places will have technology and some places will not. And you can see how you can make a really nice work using all this anatomical knowledge. São Paulo is the biggest city here in South America, and we have the same two environments. We have the public hospitals that most of them will not have all this technology, and of course the private hospital that they are more equipped. But we use the craniometric points all the time. Even if we have all the technology, we are always confirming the knowledge that we have. So if you use it all the time, you will become a lot used to this. So the craniometric points are easy if you begin using them. And about the ventricular access, a lot of them are very interesting. I came from a training that we are always doing frontal approaches, just cocker points, and then later on I get into a group of neurosurgeons that we work together, and now we are using cockers and parietal points also, but just these two. So I would see that perhaps it's best to choose one or two and to have experience, really good experience in one or two, but of course know the other ones. But I don't know if some people, it's since we have a lot of people here, it's someone using all these points, or people are really more using one or just two of them. It's interesting to see all the possibilities. But do you yourself use a lot of these points, or do you use just one of them?
Well, thank you, Eduardo, for the comments, and I definitely conjure with your remarks that craniometric points are always the first thing to be mapped on the patient's head. So even though we have navigation system in our place, which we were not using few years back, we were always using craniometric points. So even till this date, when we have a navigation system set up on the patient's head, we always start with the craniometric points placement and relationship of the pathology to these craniometric points. Now, regarding your comment to the ventricular key points, this is very valid. We do not use many of them. This all mention has been done so that people should know about the various options. So I've discussed about both the key points where the ventricle can be hit using the standard localization, and also when we open the brain and we want to localize the ventricle, because when the skull is off, the cranial pointed points are gone. So one should be aware of the pains point or the use point. So if in case somebody fails in one can actually change the local the position and can try to hit it. But as you rightly said, we should always try to stick with one method, particularly at one location, so that our chances of accuracy in subsequent surgeries are far more superior. And of course, all these points which I have mentioned, there are data in the research that the accuracy of localization in the ventricle, I think the ventricle is up to 95%. So most of these simply work. Only thing is that many of us are always tuned to some or the other than the others. So we can have more comments from the attendees on this particular aspect. This is very interesting, basically.
Also, from Dakar, Zega said they always use Coher and King's point. I think Coher is the most popular point to use for OEP shunt surgeries and DVD surgeries. And also, as you know, almost maybe more than 50% of neurosurgical centers in the world don't have navigation or other systems. Because of this, in residency education, this craniometric point is very important. In my hospital, previous hospital, with my residents, I always want them to draw the entry points and the craniotomy place. Then we check with the navigation, always to educate them. I think, as Ilbas says, you can have all these kind of technologies, and nowadays we use the VR HoloLens or other device. But most of the time, the most important thing in neurosurgical case is your knowledge of neuroanatomy and points, because everything can be, how can I say, can be broken or something. It can happen, but you can use your knowledge every time, and in any place you can perform surgeries with your knowledge. And I think Libas and Tapa didn't leave any point to be discussed. Also, I didn't see any question in our
Can
chat.
I have a comment? Excuse me.
Yes,
Yes,
Nargiza.
thank you very much,
Yeah,
Dr. Ribas, for your nice presentations. I just want to say that for young neurosurgeons and for any neurosurgeon, there should be techniques and tools which you can rely on. So when we talk about the skull and craniometric points, it's something which we can blindly rely on. And let's not forget about emergency cases. If we can have time for during the elective cases to have some all kind of navigation and the MRI, and we can evaluate all these things. During the emergency cases, we have to work fast, and I'm not only talking about the EVD, external ventricular drainage, or VP shunt. It can be any type of glioblastoma when we have patient in emergency which is deteriorating, and you should work fast. So I have been working in India for 3 years, and it was sort of rural area where we did not have a navigation all the time, especially in the night, because the ORs are different for elective and emergency, and we had to rely on our craniometric points. So it is very important. Thank you so much.
Thank you. Any comments, Libas, Tapa, or from audience? I think there's no questions and any comments more.
well, I
Sure.
just wanted to ask Ribas, because he has a very good exposure on anatomical labs, and most of the neurosurgeons who are now being trained, they feel, and actually this is always right, that they should also get some hands-on experience on the cadaveric lab. So how do you suggest to the young neurosurgeons who are in the audience to create this type of experience at their own site? So any step-by-step guidance, because you had a very good experience with the types of neurosurgical labs.
Well, I mean,
Eduardo.
when we compare the anatomical labs, they are very cheap if you compare them to other labs. So I really think that every place can have an anatomical lab, because it's really more about the people working there than about the money. If you compare to any biochemistry lab, our lab is very, very cheap. And of course, there are some regulations in some places of the world. I would imagine that Islamic countries are more difficult to have the heads, to have the brain donated. But if you are just looking for knowledge instead of doing research, it's just for knowing, or you can have fellowships. And if you stray, I wouldn't say a month, but 3 months in a fellow, you will learn a lot. And of course, a lot of labs are more prone into research, because that's how they pay the bills. They want to show that they are producing and making researches. But I mean, the real point is to be a good neurosurgeon. So the labs need to respect that some people just want to learn. It's not really about doing articles and research. They can go just for learning. And if you stay 2 months, 3 months, you already have a lot of learning how to see the brain. And it can be during a long vacation. If you take a long vacation during your training, or just after training, you can go somewhere and just see the other people learning. You don't need to have a real research about this. Dr. Evandro's lab here in Brazil is closed now. He just passed away some years ago, and exactly his lab closed. But he was very famous for having people just for learning. In a way, they didn't produce a lot. There was not so many papers that they could have had, and some people say this was not good for the lab itself, but I am sure it was good for the people who were there, and they became nice neurosurgeons. They learned a lot. So sometimes the lab is just for training, it's just for learning, and our main mission is to be good neurosurgeons. I would say you can be a good researcher, but to be a neurosurgeon, is the main mission, right? So
Yeah,
Abuzer,
absolutely.
yeah,
Absolutely.
try always to have people just learning. I know maybe it's not good for the lab, but it's good for the people.
Well, I just have a comment from Ahmed Al-Jardi, and he's asking, is there any places that offer a fellowship opportunity for young neurosurgeons or lab dissections? I know of some, but then they're not cheap, and I myself have paid a hefty amount to go and have an exposure. But then these labs, which actually gives you a plastinated models, they are the best to handle, and they give you a real sense of what the anatomy looks like. Because other cadavers, which are basically from the fresh cadavers, as they say, or the wet labs, there the brain is already like not good to handle. They're liquefied, so that doesn't make too much of sense when we are doing a white matter dissection, for that matter, or any other brain dissections. This question I believe is for Eduardo. So Eduardo, would you like to comment on this?
Well, we are trying to put a lab to establish a bigger lab here in Brazil. This year now, 2024, we organized our lab for ourselves. It's just small, but I think that I'm giving for my residents now a better exposure to neuroanatomy, to the cadavers, to see how they train with the cadavers. But it's still very small, so we can just handle one person at a time. So the residents rotate, and up to now we could not open to invite people or fellows everywhere. But the next plan is to try to get it bigger. If you think about the world, I don't know actually places that they already organize. I know some places that do have their own lab. Dr. Abuzer now is just chief in a very nice lab in Istanbul. I know there are some other labs in Istanbul and China and USA. I would say this is the three biggest countries that will have this. But here in Brazil, we're trying to make it bigger. There is another university, the university that Dr. Ferri is already also a very known neurosurgeon here in Brazil. He has a lab too, but then it's more about courses. It's not really a fellowship that you stay there some time. But they are also trying to make it bigger. I think in 1 year or two we'll have better places here in Brazil. And I don't know about USA. Do you know, Abuzer, where in USA?
I am connecting from our lab. We have 10 fellows from around the world, from Turkey, from Sudan, from as you know, we have we had fellows from United States, Italy, Mexico, Ecuador. You can send an email to us. Also, you can find us in social media. For international fellows, at least 1 year fellowship. You can join one year fellowship program. I think also you can find in anywhere in Europe, in United States, there are neurosurgical, microsurgical laboratories. I think if you want to join this fellowship program, 1 year later you can join. I think with the, for example, we want one recommendation letter and your CV. Then your suitable schedule to join, then we can accept. I think Ahmed Al-Jardi, you can send an email also from Pittsburgh. And
I think, Dr. Abuzer, it's also important to mention what kind of fellowship guys want to take, either it's white matter dissection or particularly skull base, some drilling techniques, or is
So in
TMC
in
neurovascular.
our laboratory, for example, every in laboratory have their own opportunities. In our laboratory, the fellows can perform white matter dissection and also microsurgical section of the skull and skull base approach and the endoscopic skull base approach, and also tractography. They are learning how to do tractography. I think there are some laboratories only focused in skull base approach. Also, some laboratories only focused in the endoscopic skull base. But in our laboratory, mostly focused on the white matter dissections, but we have fellows doing a transorbital approach and endoscopic endonasal approach and some skull base approach. And also, Eduardo, do you want to say anything?
I want to say that if you join Dr. Abuzer's lab, you will make sure that you will get all knowledge. You will work hard, and usually Dr. Abuzer gives the task, titles for the topic and research, and they are being discussed every Saturday with Professor Gurture. So it's a proper fellowship work from morning till evening, which at the end of the day will give you a big exposure and experience. So we can text and Gmail Dr. Abuzer.
I gave my mail. I wrote in the chat box. I think we can close the session because we spent 1.5 hours. I want to thank all lecturers and the audience. And next week we will talk about the head and neck anatomy. Please join us. Thank you, Libas. Thank you, Tapa. Bye-bye.
Thank you so much.
Thank you. Bye-bye.
I'll say hi to Dr. Ivana too, that didn't say a word, but it's nice to see you all.
Bye-bye.
And I really like your background, Eduardo.
Well, actually, this is Friday, and I'm a little bit of vacation today, but it's a pleasure to give this lecture. And I just came to the countryside of
Oh,
Brazil.
wow.
It's full
That's
of
great.
nature, so I just came.
Beautiful, wonderful.
It's a one-day vacation.
That's
It's a
completely
neurosurgical vacation, one day.
Enjoy it. Enjoy it. Have fun.